with you our experience of our STEMI program. Can we have the slides up, please? Oh, yeah. So before I start, I'd like to thank the organizing committee for giving us the time to share our experience on this platform. I'd like to thank our colleagues who are moderating these sessions. Before I jump into STEMI care, I'd like to share with you a single experience, a scenario we ran with 2 years ago. I had the pleasure of interacting with this Indian patient. He's 47 years old, who has hypertension. He was a smoker. He had chest pain for 3 hours. He was picked up by our colleagues from the emergency medical services and was brought to us because of this ECG, which shows inferior STEMI. We are using this patient to open the platform to talk about STEMI. What the current recommendation is suggesting is that if a patient has active chest pain, they should be presenting themselves to a hospital or should call the emergency medical services. In our situation here is Red Crescent or Hilal Ahmar. And if a patient is diagnosed with a STEMI, it will depend where he's diagnosed with a STEMI. If he's diagnosed in a hospital that has a cath lab or if he's diagnosed in a hospital that doesn't have a cath lab. So if he was picked by EMS or he presented to a hospital that does not have a cath lab and the ECG was confirmatory that they have an ST elevation MI, the patient should be transferred to a cath lab-based hospital if the transfer time is less than 2 hours. If it is expected that they will take more than 2 hours, then at that time the patient should be given thrombolytics to hopefully alleviate their problem. The aim of those patients when we transfer them is that we're trying to get them to get the artery open in less than 90 minutes. Even though the transfer time should be less than 2 hours, but we should be aiming to get the artery open in less than 90 minutes. But if we decided that the transfer time is longer and the patient need to be receiving thrombolytics, we should aim to give the thrombolytics within 10 minutes. So if you diagnose somebody with a STEMI, you want to give them thrombolytics, you should start it within 10 minutes. And within 60 to 90 minutes, you need to assess if they are responding or they are not responding. If they're responding fine, then they can be transferred for BCI in 48 hours maximum. But if they failed, then they need to go for rescue BCI, which is an emergency BCI to help them open that artery. Current guidelines also recommend that in the first 12 hours, primary BCI for patients presenting with a STEMI is acceptable and is the best things to be done. And if they cannot receive primary BCI, then they should be considered for thrombolytics. But after 12 hours, from 12 hours to 48 hours, you still, if they're symptomatic, can send them for coronary angiogram and BCI. But if they're asymptomatic, less than 48 hours from the onset of chest pain, then the intervention becomes, maybe acceptable. But after 48 hours, you should not be considering intervention. Why is it important? Why is it important that we take patient quickly and fast to the cath lab, to a hospital that has a cath lab ready, and take them from the field directly to the cath lab rather than, take them to a hospital where there is no cath lab and then transfer them. From 2006, the studies start to come up to show the importance of field transfer to the cath lab in patients with STEMI. What it shows that it actually reduces mortality. People who present to a hospital where there is no active cath lab will likely to have higher mortality compared to people who actually present to a hospital that has an active cath lab. And the reason for that, because time in cardiology is muscle. When patients present with an active heart attack, the time that requires you to open the artery, the longer the time, the worse the outcome. So in order to achieve the best outcome, we always have to strive to get the patient with active ST elevation MI directly to the cath lab in any shape or form, the fastest way, the best way that we can get them. What is the world experience currently when it comes to STEMI? So this data came from the European registry. And what they showed, the European registry, that out of their patients that present with STEMI, in general, in total, 72% will receive PCI, primary PCI, 19% will be thrombolized, and only about less than 10% will not receive any therapy. Saudi Arabia falls in the non-European non-European Society of Cardiology Middle East. That includes Saudi Arabia, Iraq, and Iran. And there are certain centers that was participate in this registry. And what you can see, compared to the average, we are way below, those centers that are participating. Primary PCI is done less than 50% on those patients. And the rate of thrombolytics is extremely high. We know that mortality is worse with patients that present with MI, but if you can revascularize them using PCI, their mortality is less compared if you give them thrombolytics, and even worse if you do nothing. So the best thing if a patient presents with acute heart attack, with a STEMI, try to open that artery. If you cannot get them to a cath lab, please thrombolize them. Don't sit and watch and say, they will get better, because their mortality is higher. When it comes to reperfusion rate, those are KPI. You're trying to reperfuge patient with a STEMI in less than 12 hours. The Middle East, they're doing pretty okay. But in timely fashion, like in 90 minutes framework, we're not that great. We're about 40%. So those are, the international data. Those are from Europe. How about in Saudi Arabia? What's our local data? So our local data, we have the first registry that was published in 2019, STAR registry led by Dr. Khalid Habib and his group. And what they showed, first they contacted all the hospitals in Saudi Arabia that has cath lab capability, or even they don't have cath lab capability. And what they found that out of 370 hospitals, only 50 hospitals first, they participated, okay? And then what they found that the number of people who present with acute coronary syndrome first tend to be younger. The average age is 55. The average age for STEMI in European countries and North America is about 65 and higher. And also, those patients who present, 50% of them were Saudi. The type of STEMI, where the majority were anterior STEMI, so even the worst type of STEMI. So our patients tend to present younger with the worst type of STEMI. And when you look at risk factor for STEMI versus non-STEMI, you look at diabetes, hypertension, smoking, and hypercholesteremia. All those risk factors, the important risk factors that predispose you to have heart attack, they are higher in our population compared to other population. But when they looked into number of patients that present through Red Crescent, they were a very small percentage, only 5.2% of patients, not only for STEMI, even for non-STEMI or for other. So they looked into details into what time frame those patients present. So from the onset of symptoms until the patient may make a contact with medical services, about 2 hours. And if they were contacted with medical services, whether that's in the field or other hospital that doesn't have a proper cath lab, the time is required to transfer those patients, unfortunately, is another 2 hours. So almost 4 hours are wasted before the patient comes to a proper hospital with a cath lab. And once they present there, the numbers are the same compared to any North American or European centers. Our data also, when it comes to getting ECG on time, is less than 50%. And if a patient is supposed to receive thrombolytics less than 30 minutes, again, less than 50% of our patients achieve that. And to achieve opening the artery in the required framework is also small. Not going to go into details, but even people who were thrombolized and they failed thrombolysis, only 38% of that make it to the hospital to get their artery open. So in general, we were not doing great. We actually were doing very, very bad when it comes to proper care for patients with a STEMI in our society. The mortality at 1 year was definitely higher in non-STEMI patients because they present late, but for STEMI, it's about 3.8%, which is still considered to be higher. So at that time, they initiated the first initiative in 2015, which was the Saudi STEMI initiative, and it was a pilot phase. They only did about 160 cases, and it was basically taking patients only in Riyadh present with a STEMI to 2 hospitals, King Fahd Medical City and the University, King Khalid University Hospital. And what you can see from July 2015, the number of STEMI cases that was presenting was significantly higher. But that initiative died quickly within almost 6 months. I'm going to pause for a second to bring you to this psychologist, Philip Zimbardi. He's quite known for a crazy experiment like Stanford prison experiment. But what's important before that, he talked about this experiment, or what he called broken window theory. And what he did, he brought 2 cars and put one in a poor ghetto, poor suburbs, and the other one in an affluent suburb. And he basically left the door open. So the car that was in the poor suburbs was vandalized right away. The one in the affluent suburb, nothing happened to it for 2 days. So what he did, he broke the window. And within the same time, the car was vandalized. And what this signifies that if you have a broken window, a broken thing in your system, and you fail to fix it, and you see it, it will invite others to continue to break other windows in other systems. So somebody has to step up and fix that window, otherwise it will invite more problems to come. So that happens to meet one of my passion about STEMI. Red Crescent was gracious enough. They were looking forward to start a program. In November 2021, we sat with the Red Crescent together. We initiated the first Riyadh STEMI program. And the protocol was simple. If you pick up a patient with a chest pain and you think that patient has STEMI with the ECG, you share it with us. We agree. We activate the cath lab if it's within 120 minutes. If the patient does not have a STEMI or borderline, then he go to ER. So I'm going to take you back to the case of the Indian guy. So this was the first STEMI case in our program in November 2001. So the patient came with active chest pain, inferior STEMI. What we can see here that his LAD has a significant occlusion in the mid-segment, but his LCX is fine, and his RCA was completely occluded. And we fixed that right away. And if you look at the time from the time where the emergency medical service arrived until the patient has his artery open is 33 minutes. That is a very, very short time and very good time. So the patient was brought the next day, we fixed the other artery, and he was discharged. And here I'm sharing with you our experience in King Fahd Medical City. So for over the last 18 months, we're starting in November of 2021, we had only 38 patients coming through the Red Crescent, and you could see the number increasing. So in 2022, we had 200 patients coming through the Red Crescent, 116 coming through our ER, so the ratio was reversed completely, and so far it continued to be the same, most of our patients coming through the Red Crescent. And here's the number. So compared to what Dr. Khalid Habib and his group found in 2015 survey with through STAR 1, from the time of activation until the emergency medical service arrive now, it's about 20 minutes. And from the arrival until the ECG is done, it's within time frame of 10 minutes. And the average time from first medical contact until we cross with a wire, the artery, is 68 minutes. So we are within the KPIs of the guidelines. We're actually doing better than most of the country right now if we continue on this time frame. And given all the effort that was done by our colleagues in the cath lab, interventional cardiologists, nurses, technicians, and the help of the administration and the support of our leaders in the cluster 2, alhamdulillah, we were awarded ADA award for the best cath lab this year. And with that, I would like to conclude my presentation. Thank you so much. Now I'm going to ask my colleague, Dr. Abdullah Al-Hamdan from Red Crescent. He will share with you some more information about the STEMI program. Thank you.